evening. Thank you for joining us this evening. It's going to be a fantastic topic about IUI versus IVF and the different treatment protocols and who they may be suited to. And joining me this evening, we have Dr. Venkat, who is the Medical Director at Harley Street Fertility Clinic. And we also have Dr. Verstraete, is that how you're saying your name?
Yes, perfect.
Who is also a fertility specialist at Harley Street Fertility Clinic and used to be an OB as well. So I'm Eloise. I'm the founder and CEO of Fertility Help Hub, which has been going for 3 years now. And it's a lifestyle platform to support people who are struggling with infertility with expert resources and community. And Dr. Lieve, would you be happy to introduce yourself?
Right, I'm Lieve Verstraete. I work as a consultant here at Harley Street Fertility Clinic. As you can hear, I'm not English, so I'm Belgian, and I did my medical training in Belgium. Afterwards, I worked as a fertility specialist and an obstetrician in Germany, in Switzerland, in France, and in the UK. So Dr. Venkat and I, we worked together 20 years ago. So we found each other again 1.5 years ago, so we're working together again.
Wonderful. And Dr. Venkat, we've done many events together before. I love sharing your expertise with our readers, so welcome. Please, could you give yourself a little introduction and a little bit more about Harley Street Fertility Clinic as well?
Thank you very much, Lois, for the opportunity. So I'm Dr. Geeta Venkat. I'm the founder and director of Harley Street Fertility Clinic. And I don't want to say how many years of experience I have because it will show my true age. So we have lots of experience. Like Dr. Verstraete said, we worked together in another fertility clinic with a pioneer in the IVF field. His name is Professor Ian Croft, who was with the people, Robert and Edwards and Steptoe, who made the first IVF baby, Louis Brown, who is now become a public speaker and speaking everywhere about IVF and other things. And, my experience has been varied. I worked in 3 major IVF clinics and mainly in Harley Street area. I learned a lot and gained good experience. And slowly then I thought it was time for me to set up my own clinic with a special purpose. Here we say it's definitely patient focused.
Thank you. Okay, so please could one of you start by explaining about IUI?
Right. So I'm going to start with IUI, and Dr. Venkat will then continue with more explanation about IVF. So first I will start what is IUI. So IUI is a procedure where we use a small catheter to inject a sperm sample which has been prepared and washed in the lab. And with this small catheter, we will inject the sperm into the uterus. And of course, this will be done around the time of ovulation when the egg is released and when we have the highest chance of getting a pregnancy. So the sperm we use can be either partner sperm or donor sperm, and then it's known as donor insemination. The next slide. So who might benefit from IUI? One of the first indications is mild male factor infertility. This means that when we have the results of a semen analysis and we see that one of the parameters is borderline, either the morphology or the motility or the concentration, but not bad enough to go for IVF, we might try to use this sperm in an IUI cycle, because when we take the sperm sample and in the lab it will be prepared, the best sperm, we will have a concentration of the best sperms, which we will inject in the uterus. So this is one of the indications. Another indication is unexplained infertility, which means that when we do investigations and everything is fine, so the woman has a fine uterus, tubes are open, ovarian action is normal, the sperm is perfect, then sometimes we might think maybe an insemination could help, by putting the sperms already in the uterus more closely to the egg. Another indication might be mild endometriosis. I don't know if you know what endometriosis is. Endometriosis is when small pieces of the lining move inside the muscle tissue of the uterus, which we call then adenomyosis, or further away in the ovaries and form cysts. And maybe you might have heard of chocolate cysts, which are endometriomas. Sometimes endometriosis can also go in the peritoneum, which is the lining of the abdomen. So IUI is only an indication when it's really mild endometriosis. When there's chocolate cyst, it's probably not the best indication. So I have to say immediately, there's those three indications. So the male factor, the mild male factor infertility, the unexplained infertility, and the mild endometriosis are subject of debate. So the NICE guidelines of 2013 advise against those indications. The NICE guidelines say that a couple should try 2 years of having unprotected intercourse, and if not getting pregnant, then go to IVF immediately. But in most of centers, these indications are still used.
Can I just ask you, does that depend on the woman's age as well?
Yeah, of course. Everything depends on woman's age. Yeah, but I'll come back to that later. Yeah. Another indication is female cervical factors, which means that the mucus is hostile for the sperms. So we might think that by using a catheter and bypassing the cervix and putting the sperm directly in the uterus, that this might help to get pregnant. Then, of course, donor insemination for same-sex couples or for single women, which is not clear. Donor insemination in heterosexual couples in case of azoospermia, which means when the partner doesn't have any sperm, then the only way of having a child is by using donor sperm. And then also one of the indications is for couples struggling with intercourse because the male partner has maybe erectile dysfunction, or the woman is having painful intercourse. So then doing an insemination can help. So the next slide. Then requirements for IUIs. So of course we need to have an ovulation. Without ovulation, no pregnancy. But of course this can be natural, but also we can induce an ovulation. Second, we need to have sperm, which is in quality and quantity suitable for insemination, which means that if there's a severe sperm factor, this won't be used. We can't use it for IUI, then we have to go for IVF and more ICSI. There should not be any local infections. That's why if we're going ahead with IUI, we always ask women to have a high vaginal swab to check for infections in the vagina. And the male partner, we ask to have a semen culture, because you can imagine if there's an infection in the sperm and we inject this sperm in the uterus, that there won't be a pregnancy. One very important factor is the patency of at least one fallopian tube. As you know, the sperm has to swim up in the uterus. Even when we put the sperm inside the uterus, the sperm has to swim into the fallopian tubes. And if the fallopian tubes are blocked, then the sperm can't reach the egg. So this is one of the requirements, a very important requirement. And therefore, we always check the tubes before we go ahead with IUI. And we can check the tubes by several means. And what we do in our center here in Harley Street is we do it by HICOSI. HICOSI is an ultrasound procedure. We put a small catheter inside the uterus. We inject some dye inside the uterus, and we check by ultrasound whether the dye is coming out of the tubes. Another way of checking the tubes is by hysterosalpingogram, which is an X-ray. So, and the other way is by laparoscopy. It's the keyhole surgery where you can see directly whether the dye is coming out of tubes. And then another requirement is absence of pathology in the uterus, but that's for IVF as for IUI. Yeah. Next. So how is it performed? We can do IUI in a natural cycle, which means that we're not giving any medication. So what we do is you come at the beginning of your cycle on day 2 or day 3 of your cycle. We do a scan, we check whether everything is fine, and then we don't give you any medication. We ask you to come back on around day 10 of your cycle. We check whether a follicle is growing, and according then to the size of this follicle, we will ask you to start ovulation kits. And when the ovulation kit is positive, so when you have a positive ovulation test, we will plan your intrauterine insemination about 24 hours after the positive ovulation test. The other way of doing an IUI is in a medicated cycle, where we also ask you to come for a scan on day 2 or day 3 of your cycle. We do a scan as well to check everything is fine. When everything is fine, we will give you tablets or injections to start on that same day. The tablets we give are clomiphene citrate or letrozole. It's very easy to take. It's 1 tablet a day. It's 5 days. If sometimes it happens that the tablets, the clomiphene citrate or the letrozole is not working, and then we have to go ahead with injections. So the FSH injections. So after 5 days, you take 5 days the tablets, then around day 10 again, we ask you to come back. We check whether follicle is growing, whether your ovaries are reacting on the medication. And if, according to what we see on the scan, we will ask you to come for another scan. And once the follicle has a size of about 18 millimeters, we will trigger your ovulation by means of an injection. We will do then the insemination 36 hours after the trigger injection. Yeah. So differences between the natural cycle and medicated cycle. So you can understand the natural cycle is more natural, not taking any medication. Sometimes it can happen that we will give you an injection to trigger your ovulation even in natural cycle. Medicated cycle, because of the medication, because of the monitoring by ultrasound, it's more controlled. The natural cycle has a slightly lower chance of success. The medicated cycle, when we're giving the medication, one of the things which can happen that more of one follicle is growing, and actually that's what we want, that we have 2 follicles. So you can understand when there are 2 follicles, there is a higher chance of getting pregnant with one of the follicles, but on the other side, there's also the risk of multiple pregnancy. So that's why we also ask you to come for scans before we trigger, before we induce the ovulation, because if there are too many follicles, we will cancel the cycles because we don't want you to be pregnant with a higher multiple pregnancy, because the risk for the baby, it's too high. Risk of prematurity, risk of low birth weight. So we want to avoid at all means like a higher multiple pregnancy. So twins is fine, but triplets is already a risk. Then the success rates of insemination, success rates range from 5% to 15% live birth rate. Of course, everything depends on age, and in fertility, age is really very important. So if you're under 35 years old, your success rate will be more up to 15%. If you're over 40 years old, your success rate will be around 5% or lower. All right, and so I give the word now to Dr. Venkat.
Thank you, Liva. Hello, everyone. My colleague Liva has beautifully illustrated the intrauterine insemination treatment. Now I'm going to talk about IVF in short, or it is known as in vitro fertilization. So this is a totally different treatment. I know we are sort of debating about which treatment is better, but we are not comparing the like here, because the fertilization actually takes place outside the body. If it happens inside the body, it is called in vivo. Whereas because it's happening outside, it is called in vitro fertilization. It is actually a spectrum of treatments, not one treatment like IUI. It's a spectrum of treatment because you can add few things to that. Supposing there is an issue with the sperm, partner sperm, then what we can do is ICSI, intracytoplasmic sperm injection, that is to improve the success rate, because with the low sperm count and other issues, the sperm may not be able to fertilize the egg. And we also choose the best sperm for injection by a technique called intracytoplasmic morphologically selected sperm, and other things like if you want donor eggs or donor sperm, all these are all done with the IVF treatment. That's what, and we can also do embryo testing, which adds to it. So this is all and comes under the IVF umbrella. Okay, now what does it mean, IVF? So we give stimulation to the woman, make the eggs grow and collect the eggs and prepare the eggs. Now the male partner produces the sample and we prepare the sperm and fertilize the eggs either by just inseminating them together or, like I mentioned, injecting the sperm into the eggs. And then once they are fertilized, they become embryos. We grow the embryos to advanced stage embryo that is called blastocyst stage, which takes about 5 days. So to start with, on the first day, the embryo is one cell stage. Now on the 5th day, when it becomes blastocyst, it contains 100 to 120 cells. So there is a huge improvement and it's well-developed embryo that's called a blastocyst. This is either transferred into the uterus of the woman to achieve a pregnancy, or sometimes we freeze the embryos to transfer in the following cycle so that the stimulation effects are all done, gone from, that is, the woman has recovered from the stimulation effects. And sometimes we transfer one embryo and the couple have more embryos, we can freeze them for future use as well. Next slide, please. Yeah, right. So like we discussed with IUI, where can we use IVF? So supposing there is a mechanical problem, the tubes are blocked, the roads are blocked, that means we have to use the bypass or overcome the problem by doing IVF. And women with unexplained infertility, where we don't know the issue, main issue involved, and severe endometriosis, this is the treatment of choice. And again, when the male factor infertility is severe, for example, extremely low sperm count or low motility and low morphology, all these things, we do IVF using ICSI technique, ICSI, that is intracytoplasmic sperm injection. And when women have low ovarian reserve, this will be the treatment of choice. And therefore, you can see the common indication is only the unexplained infertility, where we can use either IUI or IVF. But all the other conditions, you can see that if the tubes are blocked, then there is no way the sperm and the egg can meet by the IUI technique or even natural conception. Therefore, IVF is the only treatment of choice or option available at that stage. And women with severe endometriosis or low ovarian reserve, severe male factor, the treatment of choice will be only IVF. There is no option of using IUI under these circumstances. Next slide, please. So what do we need for IVF? It's like any other, even IUI treatment. We need eggs, we need sperm, and we need a good uterus to carry the baby. That is the most important thing. So we always say, they ask us what is the success rate and how it depends on the number of eggs and the quality of the eggs and the number of sperm and the quality of the sperm. So the quality is very important. That's why the success rate depends on the age of the woman and to a certain extent, age of the male partner as well. And we should have a good carrier bag, we say, that is the uterus in the woman. If the uterus is full of fibroids, the success rate will be reduced. Or if it has any other pathology, then the success rate will be reduced. That's why it's important to have a good, healthy uterus. Next slide, please. Then compared to IVF, compared to IUI, we talked about using IUI, we talked about using natural cycle or stimulated cycle. Here also in IVF, there is a possibility of using natural cycle or mild stimulation or conventional full stimulation cycle. But generally, IVF means we use the stimulated cycle because this gives the best chance of success. As clinicians, we always say we must do our best for the patient. That means we must do everything to maximize your chances. That's why we go for the traditionally stimulated cycle. We give hormone injections to stimulate the ovaries, which will produce the follicles, and we will monitor with ultrasound scan as well as blood test to check the hormones. So we combine both the methods of monitoring to assess the response, and the purpose of this assessment is to adjust the dose of the hormones. Therefore, we get the optimal outcome, that is optimum number of eggs and good results. And once these eggs are ready and the follicles are ready, we collect the eggs on a particular day, we give a trigger injection, and then 36 hours later, we collect the eggs. This is done under anesthesia. It's not general anesthesia, it's done under sedation, but there will be an anesthetist to give sedation and monitor you during the procedure. Then once the eggs are collected, as I mentioned, the male partner sperm will be prepared. Both will be mixed or injected, and embryos cultured for 5 to 6 days and transferred or frozen or transferred one embryo and freeze the remaining surplus embryo. Next slide, please. Now we talk about the success rate. As you know, in the IUI, the success rate was 15%. Again, it depends on the age. If somebody is older, say in their 40s, the success rate drops down to 5%. And then the younger women, say in somebody in 25 years, in their early young age, their success rate is excellent with 15% in IUI. But that is the maximum we can achieve with that simple treatment. However, here also you can see the success rate varies according to the age. You can see the age depicted here. And the success rate, when somebody is younger, the success rate is better generally in these graphs. You can see, don't just ignore the colors for the time being. We say the success rate is something like 50% when someone is under 35. When someone becomes more than 42, you can see the success rate is lower, less than 10%. We usually say about 5%. Now we see the different colors because what we do in our clinic, as I said, we want to maximize your chances, and we do the different things to improve the outcome. So there is a technique called pre-implantation genetic testing. That is what is written as PGTA. We usually recommend it to all the couples. Even if they are young, it's worth doing this because 40% of the embryos made by the IVF treatment are chromosomally abnormal, even in someone who is under 35 years. This rate or proportion increases in a woman who is over 40 years old. So this becomes something like 60 to 70%. That means more and more embryos become chromosomally abnormal as one gets older. So if we use this technique to select the right embryo for transfer, because nowadays we don't transfer 2 embryos and 3 embryos like we used to do when I started IVF treatment. Eloise will sort of remember that those days. Then everybody used to have twins. That was quite common. Nowadays, we recommend people to have 1 embryo to have 1 healthy baby. That is the ideal outcome. So if we use this technique, we are able to select the right embryo for transfer. Say one couple has got something like 5 embryos. If someone is young, good ovarian reserve, they get 5 blastocysts. All 5 blastocysts are not going to be chromosomally normal. Some of them will be abnormal, but the embryo might look very good in grading. And we think that, okay, this is an AA embryo, let's put it back. But if you don't know whether it is chromosomally normal or abnormal, you are doing the embryo transfer blindly. And if it is an abnormal embryo, you don't get pregnant, or even if you get pregnant, it's going to be a miscarriage or ultimately chromosomally abnormal baby. When we are interested in having or taking home a healthy baby, doing this test will help us to choose the right embryo and put back. Therefore, it reduces the time you are going home with the live birth. That is why PGTA is important. And you can see that now. Look at the colors. The pink color is IVF without doing PGTA. Of course, at younger age, and then this blue color is IVF with pre-implantation genetic testing. You can see that definitely with this, the success rate goes up, even in women under the age of 35. However, the success rate is not extremely different here. Whereas when you come to over 40, you can see the success rate without PGTA is, this is IVF without PGTA, so low, like I said, 5%. But with PGTA testing, the success rate comes nearer to a 30-year-old. That's what we are trying to do by doing this PGTA. And if you see that live birth success rate is something like 60%, which is brilliant. And we also see the cumulative pregnancy rate over 3 cycles is over 90% if you use the PGTA, which is excellent. And that's why most of the patients who have had unsuccessful attempts in other clinics come to us, and we see many of them getting pregnant in their first attempt in our clinic because we use these extra techniques to maximize your chances. And that is the aim in our clinic. We want every patient who walks through the door, our front door, to go home with the baby in their first attempt. We don't want them to have attempt after attempt doing IVF treatment. Next slide, please. Yeah. So, okay. Now we compare. This is a comparison between Leva and me. So we can say, we can't say which is a better treatment, because I told you we are not comparing two similar things here. We are comparing apple with orange. They are all totally different. I will say my feeling is, okay, this is IUI is a simple, more natural treatment with low success rate, but the IVF is more invasive, more expensive, but with much higher chance of success. Like you see, with 60% live birth rate per embryo transfer in our clinic with the embryo testing, and 94% cumulative pregnancy success rate with 3 attempts. So therefore, you are more likely to go home with the treatment. And we usually transfer 1 embryo, so we can control the risk of multiple pregnancy with the IVF treatment. Whereas we don't have so much control with the multiple pregnancy with IUI. And chance of success, we have discussed 15%, and it comes near 35 to 40% over 3 cycles. So comparatively, it's just less than half the success rate. And so we can say that in mild male factor, mild endometriosis, if the couple are young and they have not been trying for a long time, then this treatment will work. But if the problem is severe and also they have been trying for a long time, then the best option would be IVF. So to put it in a simple way, I'll say, if you want to go on fast track, these days, modern life is so busy. Nobody has time to sit around, do things slowly. We want things on fast track. We want to get pregnant as soon as possible. We want to have a baby in the shortest interval, healthy baby in the shortest interval. I will say IVF is the treatment, but here IUI is for people who want more natural and early stages of infertility, we can go for it. And also in some cases where we are using donor sperm, say single women, same-sex couple, where they are using donor sperm, they are not infertile women. Why should we treat them with IVF and other invasive treatment? They can go for simple donor insemination because all they need is sperm at the right time in the uterus. So that's what this IUI does for such couples, such women, single women or same-sex couples. We can use IUI treatment to give them a baby. And of course, if they are over 40 years, then the same principle applies and they should think of IVF. So I would say there is no better treatment or worse treatment. If you want best success rate at the shortest interval IVF and IUI for more natural methods, these two treatments, in my opinion, are complementary to each other. It's not that one is better. There are patients where IUI can be performed and it is helpful, whereas there are patients where IVF will be the best option. So we have to say, we can't say one size fits all. We have to see who the patient is, and the treatment will be tailored according to the individual needs, wherever it is necessary. Liva, I suppose you agree with me. Do you have anything to add? I'm happy to hear.
I think it depends all from the indication and from the age of the patient. That's the most important thing, I think.
Thank you for helping the community. And if anyone has any questions for either of the doctors or would like to speak to the team, the details are there. So thank you for your time this evening and for everyone joining. I hope it was helpful.
Thank you, Elise, for the opportunity.
Thank you.
Thanks, everyone.